mechanisms of blood vessel formation. So how your blood vessels are formed. Okay, so blood vessels form in two ways. We have the vasculogenesis or genesis, vasculogenesis and angiogenesis. So vasculogenesis, veins form in situ, by coalescence of mesoderm cells into the endothelial tubes, these tubes. So vasculogenesis is where the heart and the major vessels are formed. While your angiogenesis are in which there are new vessels sprout from existing ones. So smaller vessels, mas gagmay siyang vessels are formed by the process of angiogenesis. So the molecular signals for vessel formation involve vascular endothelial growth factor or your VEGF, VEGF, and their receptors. So VEGF or VEGFRs. Okay, so those are the molecular signals, in forming your vessels, blood vessels. Okay. Okay, so these are the examples of blood vessel abnormalities. This child with focal capillary hemangioma. So this one is the most common tumor, in infancy, capillary hemangioma, and small ones like these are usually resolve on their own with no residual problems. Ang mga pula-pula galing siya nga looks like this. Since this is a blood vessel formation, matuslo ka trauma ni siya, very bloody ni siya, very bloody. So this one looks benign. It's so small. This is the most, as I've mentioned, this is most common tumor in infancy. How about this one? You see, this is a diffuse capillary hemangioma. These lesions are large and tend to have more secondary problems, such as airway obstruction, ulcerations, and scarring. Ay, kaluoy man siya. So, this is an abnormality which is associated with other more problems. Like, for example, siya, I think may mga skull deformities ni siya, and look at the eyes, Okay, and this one, very challenging in his anesthesiology is because how can we insert our tubes, Okay? Sige. Again, these are repeat slides, the illustration of the pharyngeal and aortic arches. So, as mentioned, there are 5 well-developed aortic and pharyngeal arches, and each pharyngeal arch contains an aortic arch. And aortic arches are numbered 1 to 6, in which the number 5 never forms or very rudimentary. Wala siya sa use. Okay? And the arches are never all present simultaneously. Instead, the most cranial ones form and then differentiated into more caudal one, as more caudal ones are forming. And the aortic arches differentiate into vessels supplying the head and neck and upper limbs. Okay? Ang atong mga aortic arches supplies the head and neck. Okay. This one, this is schematics, showing the rearrangement of the aortic arches into their definitive vessels. So, in forming the definitive pattern of arteries in this region, some parts of the arches and dorsal aorta undergo programmed cell death. Nakautod-utod man sila. And as these vessels regress. So, major vessels are formed by the third. Okay? Major vessels. Anyway, it will be summarized later in Okay. We move forward lang, anay, ha? You see? Ay, hindi ka isa lang. Okay. Major vessels are formed by third carotid, no, like carotid system. Fourth, developed in subclavian, no, subclavian on the right, and the arch of the aorta on the left. And the sixth vessel forms pulmonary arteries and ductus arteriosus. Okay, this one. So these are the vessels that were that regresses, no? That regress. These are the vessels that regress in time. Okay. How about this one? These are the postnatal this is the postnatal arrangement of the aortic arch derived vessels. So here we have our aorta, ascending and descending, and we have the pulmonary artery. This one goes to your lungs, no? This one supplies the head and neck. Okay? Mga carotid ni mga ara na nasa neck going to the brain. Okay? Okay, this one summarizes, no? This one summarizes the major aortic arch and its derivatives. Okay? So your aortic arch, as mentioned, your aortic arch later becomes your maxillary artery. Aortic arch 2 becomes trapezial, no, or hyoid artery. Third, carotid. Fourth, on the left side you have arch of the aorta, and in the right you have subclavian. And again, the fifth one disappears, no, or become rudimentary. And your sixth aortic arch will later be your pulmonary arteries and ductus arteriosus on the left. Okay? Okay. So this is an example of the aortic arch defect, no? So normally, amo ning tsura sa imong aorta. This is the normal position of the aorta, no, and the artery arches. So these are the example of the aortic arch defect. Sorry. So again, this is the normal one, and then you see there's a double aortic arch, no? And sometimes abnormalities in the normal patterns of cell death occur, no? Hindi siya nag-cell death, so nag-retain siya ng iyang position, original position. So resulting in defects in the head and neck vessels. So in this case, part of the right dorsal aorta fails to degenerate, creating a double aortic arch, no? And this double aortic arch can cause difficulty of swallowing because you see, double aortic arch, ipit niyang imo trachea and esophagus. So sometimes when you tulon, no, kung damo imo nakaon, dako imo tulon, kisa nabudlayan ka maginawa because kina-compress man sang esophagus mo ang imo nga trachea. So that is one of the manifestation of our patient with double aortic arch. Okay? And it is an vascular defect. Next one, we have anomalous right subclavian artery. So in this case, there is an abnormal obliteration of the part of the right aorta. Okay? And the right dorsal aorta, resulting in abnormal origin of the right subclavian artery. So the anomalous vessel, so anomalous vessel wraps around the esophagus and may cause difficulty also of swallowing. Kikingkupan niya gidyang imo esophagus. Also, ginaipit niya man gyapon. So we have the same problem, no? Dysphagia or problem with swallowing. Okay? Difficulty in swallowing. Okay? Another anomaly, we have coarctation of the aorta. So this may be preductal, no? Preductal or postductal. So ang preductal, if this is the duct, no, preductal kita, this is twice as common in males, no? Twice as common in males, and postductal is more common than preductal. Okay? Dali lang, natawag kong iyang problem. So, postdactyl more common than predactyl, and in postdactyl, the blood reaches the lower parts of the body through the internal thoracic arteries to intercostals to the aorta. Okay, so intercostals cause rib notching, which can be seen in X-ray. No, there will be a hypertension on the right side, right arm, while hypotension in the legs. No, in the legs. Okay, so again, this is a 4-week embryo to point out the umbilical and vitelline yolks arteries. There is a dalong. So umbilical arteries remain paired and initially arise from the aorta. Okay, so if this is our aorta, the red one, okay, this one. Rise to the aorta, and later their connection is via the common iliac arteries. And after birth, the proximal segments of the umbilical arteries are retained as the internal iliac and superior vesicular arteries. No? Distal portions become fibrous and to form the medial umbilical ligaments. So let's go to the artery supplying the gut tube. No, gut tube. So this illustration is showing us the blood supply to the gut from arteries derived from vitelline vessels. Okay, and celiac artery supplies the foregut. There is a level na diri, no? So celiac artery supplies the foregut. The superior mesenteric artery supplies the midgut. No, midgut, meaning later on kung ano siya, ang middle portion of your intestine, no? And middle segment of the intestine. And inferior mesenteric artery supplies the hindgut. Dalong. Okay, so again, let's go to the derivatives of your vitelline and umbilical arteries, veins, and the liver. Here, the liver grows as a proliferation of gut endoderm, no? And the liver buds, we call it liver buds, into the septum transversum. So as the liver cell proliferate, your vitelline vessels in the region, together with some parts of the proximal segments of the umbilical veins, form the hepatic sinusoids. In this slide, still on the derivatives of vitelline and umbilical veins, after contributing to the development of hepatic sinusoids or liver sinusoids, the proximal portion of both umbilical veins degenerate. This one, no? Naglatula na siya. And the distal portion of the right umbilical. And there's a large, and the distal portion of the right umbilical vein also degenerates. Okay? And the large connection here, is formed between the left umbilical vein and the right hepatocardiac channel called the ductus venosus. So blood flow now flows from the placenta through the left umbilical vein via the inferior vena cava, and inferior vena cava, which is derived from the right hepatocardinal channel. Okay. Again, on a 4-week embryo, this just to point out the cardinal veins. This one. So at 4 weeks, are just starting to develop, and so the cardinal veins are sufficient to drain blood from the head and body wall. No? So as organs develop, the cardinal system is insufficient to drain each new organ. So separate drainages are established that eventually form the definitive vessels. Okay. Okay, let's go to the formation of veins from the body wall and organs. So the connection, this one, the black vessels, the connection forms between the two anterior cardinal veins called the left brachiocephalic, left brachiocephalic vein, and the anterior cardinal veins form the jugular system. This one. And the right common cardinal vein form the superior vena cava. This one, the right side, no? This superior vena cava. Most of the posterior cardinal veins degenerate as new veins form, no? And new veins include supracardinals, okay? Supracardinals that drain the lower extremities. Okay, so this one is the summary of the slide. Supracardinals drain the body wall, the hemizygous and azygous systems. Ang subcardinals mo naman, they drain the kidneys and renal and gonadal veins, also the sacrocardinals, lower extremities, and iliac veins. Amo lang ni siyang importante, okay? Okay, so again, this is a repeat slide, no, of a 7.5 day embryo during the formation of your syncytial trophoblast and cytotrophoblast. No? You remember this picture? So here, the syncytial trophoblast forms the invasive layer. Siya ang nag-burrow sa imong endometrium. Endometrial stroma, endometrium is a part of your uterus, okay? So the invasive, the syncytial trophoblast forms the invasive layer for implantation and will erode, no? It will erode tissues including the blood vessel, okay? Siya mga blood vessel. So the cytotrophoblast on the outside consists of proliferating cells that move into the syncytium. Again, illustration of the implantation sites showing continued development of the syncytial trophoblast. So at approximately 9 days of development, spaces called trophoblastic lacunae appear, no, in the syncytial trophoblast. By day 12, this syncytial trophoblast has eroded, no, the maternal vessels which bleed into the lacunae. The new layer of cells called the extraembryonic mesoder here has formed and started to separate into two layers, one next to the yolk sac called the visceral layer, and one next to the cytotrophoblast called the parietal or somatic layer. Okay? Review lang ni siya. And we go to the formation of the villi. This is the illustration showing the continued placental development and formation, no, of the villi. So by day 13, the finger-like projection, it's called the primary villi, are consisting of cytotrophoblast covered with syncytial trophoblast project into the blood-filled lacunae. This one, mga villi. So primary villi consists of a cytotrophoblast core covered by syncytial trophoblast. Ang secondary villi naman niya have mesodermal core from the chorionic plate, while the tertiary villi have blood vessels in the core, no? Basta at least pala yung mga villi. The object is to create as much surface area, no, as possible to transfer the nutrients from the mother to the fetus. Okay? And note that the two circulatory systems are always separated by tissues, so there is no mixing of fetal and maternal blood. Okay? Dapat hindi na mag-mix ang ila blood nga duha. There is always a compartment siya, may division. Okay? So, we go to the formation of the villi at 4 to 5 weeks of development. So the cytotrophoblast continues to grow, no, and proliferate until it breaks through the cytotrophoblast and creates the cytotrophoblastic shell. So by now the numerous branching villi extend from the chorionic plate to this shell. So the villi consist of numerous blood vessels have started to form the connecting stalk. Ganyan na ng villi. Basta muna siya mga spiral arteries, no? Nag-connect ang mother to the fetus. Okay? So we go to the blood supply of the placenta. Maternal blood reaches the placenta via these spiral arteries. Spiral arteries. That these spiral arteries penetrate the cytotrophoblast shells and empty into the intervillous spaces. Maternal veins drain to these spaces, no? Intervillous spaces. This one. Okay. Next, villi form development at 4 weeks and 4 months. Okay, so at 4 weeks, the villi have some branches, no, with many vessels until and still differentiating. The barrier between the two, between the fetal and maternal blood, consists of syncytium, the cytotrophoblast, the connective tissue, and the vascular endothelium. Okay, by 4 months of development of pregnancy, the barrier has thinned, no, to syncytium and the vascular endothelium to facilitate transfer of nutrients, no. So villi now have numerous branches with 1 or 2 main stems that anchor the placenta. So this one, we go to the cotyledon development. And here, the mature placenta has a segmented appearance because of the formation of 15 to 20 cotyledons and proliferation of the decidua, which is a functional layer, no, of the endometrium shed during parturition, no, grow downward and between collections of villi. These decidual septa never reach the chorionic plate and so never completely separate the placenta. So blood flows into the cotyledons under the pressure through the spiral artery, no? Okay, through the spiral arteries and leaves the cotyledons through the endometrial veins. Okay, so intervillous spaces in the placenta hold approximately 150 ml of blood and is replenished 3 to 4 times per minute. No? Tasig ang exchange of blood from the maternal side to the fetus through the spiral artery. So we go to the fetal membranes and the placenta. So this is the illustration of the membrane and the placenta at 8 weeks and 12 weeks. So here, the placenta forms the embryonic site The placenta forms on the embryonic side and is anchored in the decidua basalis, no? Basalis, during 8th week of development. So this surface has villi and is called the chorion frondoso, or the leafy chorion. Okay, the embryonic surface is covered with decidua capsularis, and has a chorion leaf or smooth chorion. Okay, this slide. So during 12th week of development, the amniotic cavity expands with amniotic fluid such that the amnion and the chorion fuse. No? So amo na gid man niyang tsura nato. So this is 12 weeks of development. So fusion of these membranes create the amniochorionic membrane, and growth of the fetus and the expansion of the amniotic cavity obliterate the uterine cavity and cause fusion between the decidua capsularis and the parietalis. Okay? Mga parts ng imo nga mga placenta. Okay, so this is a disease of the newborn. We have the hemolytic disease of the newborn, or we call it erythroblastosis fetalis. And although the maternal and the fetal circulation, no, do not mix, there's some leakage, no, that occurs across the placenta. And because fetal cells have antigen on them, they can elicit an antibody response, no, in the mother. Dapat separate sila, pero sometimes there's leakage. So the most serious of this is caused by Rh antigen and can lead to the anemia, no? Anemia in the fetus. So these days, mothers at risk are identified and the problem prevented by administration of anti-immune globulins. Okay? So women at risk are treated with anti-immune globulins. Okay, so I think that's the last slide. Mas lipot din man siya vascular development. Okay,